Welcome to This Week in Critical Care. This week we're covering 9 notable papers spanning cardiopulmonary resuscitation dynamics, advanced respiratory support and nutrition strategies, and challenging clinical decisions in specialized intensive care populations. Let's dive in. We begin with new insights into how we run resuscitations, focusing on the physical mechanics of manual ventilation during advanced life support. In a multi-center prospective cohort study, investigators from Sweden and the Netherlands evaluated ventilation parameters across different airway modalities and modes during active cardiopulmonary resuscitation. Analyzing over 28,000 ventilations from 241 patients, they discovered that manual ventilation is highly variable and often suboptimal. Specifically, bag valve mask ventilations demonstrated very limited efficacy, producing a mean expiratory tidal volume of only 186 milliliters. In contrast, supraglottic airway devices yielded consistent tidal volumes of nearly 400 milliliters when used synchronously, and 333 milliliters when used asynchronously, though mask leakage increased over time. When looking at asynchronous endotracheal tube ventilation, the study revealed that this method generated high airway pressures with peak inspiratory pressures averaging 51 centimeters of water, and a prolonged time where airway pressures exceeded 30 centimeters of water, averaging nearly 6 seconds per minute. These findings highlight a critical clinical gap. Our manual ventilation during resuscitation is frequently either inadequate or excessively high pressure, suggesting we should move toward the routine measurement of ventilation parameters during active resuscitation to protect our patients' lungs and ensure adequate gas exchange. Resuscitation is not just a physical challenge, it is also a highly demanding cognitive task. In another study, researchers examined perceived cognitive load among emergency department code blue teams and how it correlates with overall team performance. Across 58 resuscitations involving over 200 healthcare professionals, the investigators measured cognitive load using the PASS 9-point mental effort scale. They found that cognitive load was unevenly distributed, peaking heavily in the team leader role, which was associated with an average score of 5.5. In a multi-level analysis, the team leader role was associated with a significant increase in perceived cognitive load, represented by a beta coefficient of 1.12. Interestingly, older age and having more than 10 years of clinical experience were associated with lower cognitive load. More importantly, the team leader's perceived cognitive load was positively correlated with the cognitive load of the rest of the team, with a beta of 0.53, and was strongly associated with worse overall team performance, with a beta of negative 0.80. This suggests that when a team leader becomes cognitively overloaded, the entire resuscitation team suffers, pointing to the team leader's cognitive load as a vital, modifiable target for future training, simulation, and clinical support tools. Once a patient is successfully resuscitated from cardiac arrest, we face the complex task of neurological prognostication. A decade-long retrospective cohort study published in Resuscitation evaluated the clinical profiles of out-of-hospital cardiac arrest survivors based on their peak neuron-specific enolase, or NSE levels, measured within 72 hours of arrest. While a peak NSE of 60 micrograms per liter or higher was found to be highly specific for a poor neurological outcome at 6 months, at over 98%, the real clinical challenge lies in the discordant patients. For instance, more than a quarter of patients with normal NSE levels went on to experience poor neurological outcomes. In this normal NSE group, poor outcomes were independently driven by older age, non-shockable rhythms, non-cardiac etiologies, higher arterial oxygen tension, and elevated lactate. Conversely, in the intermediate NSE group, over 70% of patients had poor outcomes, which were independently associated with non-shockable rhythms, higher initial sequential organ failure assessment scores, and a lower gray-to-white matter ratio on brain-computed tomography. This tells us that a low or normal NSE level is not a guarantee of a good recovery, and we must continue to use a multimodal prognostic approach that weighs systemic physiological derangements, imaging, and patient age. We must also remain highly vigilant for secondary complications in the early post-arrest period, particularly in pediatric patients. A single-center retrospective study published in Resuscitation characterized the prevalence and impact of bacterial infections in children admitted to the pediatric intensive care unit within 6 hours of an out-of-hospital cardiac arrest. Out of 203 children included in the study, 1 in 5 had a definite or probable bacterial infection recognized within the first 48 hours of admission. These infected children had significantly longer median resuscitation durations, averaging 24 minutes compared to 10 minutes, and suffered from much lower rates of survival to hospital discharge at only 33% compared to 70% in those without a definite or probable infection. After adjusting for age, cardiopulmonary resuscitation duration, and baseline respiratory support, the presence of an early bacterial infection was associated with roughly a 60% reduction in the odds of survival to hospital discharge and intensive care unit discharge. This strong association suggests that early post-arrest bacterial infections are both common and highly lethal, highlighting the potential need for more aggressive infectious surveillance or early empiric management strategies in pediatric cardiac arrest survivors. Moving from cardiac arrest to the management of acute respiratory failure, clinicians often struggle with the optimal strategy for transitioning patients off mechanical ventilation. Prophylactic non-invasive ventilation is recommended for patients at high risk of extubation failure, but the role of high-flow nasal cannula oxygen during the breaks from non-invasive ventilation has been unclear. An observational study, defined as those older than 65 years or with underlying cardiac or respiratory disease, who received prophylactic non-invasive ventilation, alternating with either high-flow nasal cannula or standard oxygen. In the unadjusted analysis, patients who received high-flow nasal cannula during their non-invasive ventilation breaks had a significantly lower rate of extubation failure at 7 days compared to those who received standard oxygen, at roughly 14% versus 18%. However, when the researchers used G computation to adjust for baseline confounding factors, the difference was no longer statistically significant, showing an adjusted difference of about 4%. While this adjusted analysis did not confirm a definitive causal benefit, the unadjusted findings and a significantly lower reintubation rate at 48 hours suggest that utilizing high-flow nasal cannula during non-invasive ventilation breaks is a safe and potentially beneficial practice that warrants further evaluation in large randomized controlled trials. For patients recovering from acute respiratory failure, early mobilization and aggressive nutrition are frequently promoted as key interventions to improve long-term physical recovery, but a major trial suggests we must be cautious. The Nexus trial, a multi-center phase 2 randomized controlled trial, evaluated whether combining early in-bed cycling with aggressive intravenous amino acid supplementation would improve physical functioning in patients with acute respiratory failure. The trial randomized 115 critically ill, mostly mechanically ventilated patients to either usual care or a protocolized intervention, consisting of 45 minutes of daily in-bed cycling and intravenous amino acids targeted to achieve a high protein intake of 2 to 2.5 grams per kilogram per day. Although the intervention was successfully delivered, achieving an average of 40 minutes of cycling per day and nearly doubling the protein intake of the control group, there was no difference between the groups in the primary outcome of 6-minute walk distance at hospital discharge. Furthermore, there were no differences in secondary functional outcomes at intensive care or hospital discharge, or at the 6-month follow-up. While the combined intervention was safe, these findings suggest that early aggressive physical and nutritional interventions do not translate into improved physical recovery for the general population of patients with acute respiratory failure. This lack of benefit from aggressive early nutrition may, however, be due to a lack of patient personalization, as demonstrated by a secondary analysis of the Eden trial. The original Eden trial found no significant difference in mortality between trophic and full enteral nutrition strategies in patients with acute respiratory distress syndrome. However, by analyzing baseline plasma samples from nearly 900 participants, researchers discovered that circulating levels of the intestine-derived incretin hormone, glucose-dependent insulinotropic peptide or GIP, predicted a highly significant heterogeneity of treatment effect. Specifically, for patients in the highest GIP tertile, receiving trophic feeds nearly halved the 60-day mortality rate compared to receiving full enteral nutrition at 14% versus 27%. This predictive effect was unique to GIP and was not observed with GLP-1 or other host immune markers. This suggests that GIP could eventually serve as a vital predictive biomarker to help clinicians identify a specific subset of patients with acute respiratory distress syndrome who will actively benefit from trophic feeding and may be harmed by early full enteral nutrition. Finally, we turn to highly specialized and challenging scenarios in the intensive care unit, beginning with the management of acute exacerbations of fibrotic interstitial lung disease. An international working group has released an updated state-of-the-art report on this serious condition. Recognizing that these events carry exceptionally high morbidity and mortality with no proven therapies, The report proposes a revised definition of an acute exacerbation across the entire spectrum of fibrotic interstitial lung diseases. Under this new framework, an acute exacerbation is defined as an acute respiratory event characterized by increased respiratory symptoms or signs associated with radiologic or histologic features consistent with diffuse alveolar damage. Crucially, the working group distinguishes this from a broader conceptual category of acute respiratory worsening, which refers to acute clinical deteriorations not caused by diffuse alveolar damage, such as pulmonary edema, bronchitis, or standard pneumonia. This new clinical framework provides bedside clinicians with a structured approach to evaluate and risk stratify these patients, while establishing standardized, uniform endpoints for future clinical trials. Another highly challenging clinical dilemma is the initiation of anticoagulation in trauma patients with traumatic intracranial hemorrhage who require extracorporeal membrane oxygenation. A narrative review and conceptual time-dependent risk framework addresses this complex therapeutic trade-off. Starting anticoagulation too early can cause catastrophic progression of intracranial bleeding, while delaying anticoagulation on extracorporeal support leads to a high rate of thrombotic complications, which this review notes occurs in nearly a quarter of patients managed with anticoagulation-free extracorporeal support. By analyzing the temporal profiles of these competing risks, the authors propose a conceptual time-dependent risk framework. Because hemorrhagic progression is heavily concentrated within the first 24 to 48 hours and drops significantly after the first week, while thrombotic risks rise steadily over time, the timing of anticoagulation should be guided by this changing balance. The authors recommend multidisciplinary bedside discussion and serial imaging to confirm radiographic stability before starting anticoagulation, rather than adhering to rigid arbitrary timelines. If you only have time for one paper this week, make it the secondary analysis of the Eden trial. This study represents a significant step forward in personalizing intensive care unit nutrition by demonstrating that a simple baseline blood biomarker, glucose-dependent insulinotropic peptide, can identify a subgroup of patients with acute respiratory distress syndrome who experience a massive survival benefit from trophic rather than full enteral feeding. Here are the key takeaways from this week in critical care. First, when performing cardiopulmonary resuscitation, be aware that manual ventilation parameters vary wildly. Bag valve mask ventilation often provides inadequate tidal volumes, while asynchronous endotracheal tube ventilation can generate dangerously high airway pressures. Second, during resuscitation, a high cognitive load on the team leader is contagious, increasing the cognitive load of the entire team and significantly degrading overall team performance. Third, when evaluating out-of-hospital cardiac arrest survivors, remember that neuron-specific enolase is not a standalone prognostic tool. More than a quarter of patients with normal levels still experience poor neurologic outcomes, driven by age and systemic physiology. Fourth, in patients at high risk for extubation failure, alternating prophylactic non-invasive ventilation with high-flow nasal cannula during breaks may help reduce early reintubations, though randomized trials are still needed to confirm a definitive survival benefit. Finally, in trauma patients with intracranial hemorrhage on extracorporeal membrane oxygenation, the risk of hemorrhagic progression drops sharply after 48 hours, while thrombotic risk rises, suggesting a personalized, time-dependent approach to initiating anticoagulation guided by radiographic stability. That's your roundup for this week in critical care. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.